Let's talk about air entrainment devices today. So we'll also talk a little bit about our high flow devices and our low flow devices. Remember, pretty much the distinct difference between the two of those is a low flow device cannot meet or exceed the patient's peak inspiratory flow demand, as opposed to our high flow device can meet or exceed the patient's peak inspiratory flow demand. So ultimately what that means is, I know we've gone over in another video and in class, we've gone over low flow devices as well as high flow devices. Today I'm going to talk about air entrainment and kind of how that works to an extent. But we have to understand the composition of the air that you and I are breathing in right now. The air that we breathe in, the atmospheric air that we breathe in, has close to 21% oxygen in that air. The rest of it is 78 to 79% nitrogen with a very small percentage of other trace gases. So the nitrogen that we breathe in, it's an inert gas, does not participate in gas exchange, helps keep the form of the alveoli, so forth, or prevent alveolar collapse upon exhalation, this and that. While the 21% oxygen that we breathe in, that does participate in gas exchange. So that's going to cross over the alveolar capillary membrane, and that is going to allow for O2 to go into the bloodstream, and then we'll have the exchange of carbon dioxide coming out of the bloodstream into the alveoli so that when we exhale, we can blow out the CO2. But we're going to talk about taking in that oxygen for the patients that we're going to be taking care of. You may be tasked with setting up a tracheostomy collar for a patient. If they happen to have a tracheostomy tube, you may be tasked with setting up just a regular aerosol mask. And I thought I had set one. Here it is. This happens to be a pediatric aerosol mask, but nonetheless, it's just a smaller version of what the adult one looks like. So this is a regular aerosol mask. And then you may have a face shield or face tent that you may be tasked with. And typically in the past, when I've done extubations, I've typically always extubated to a face shield to provide cool bland aerosol to hopefully help keep down some of the post-extubation airway edema that may come about. But nonetheless, if you have these setups, you're going to set them up to a large volume neb or a high flow oxygen delivery device. And you'll set that up with corrugated tubing. So I've got two pieces of corrugated tubing here that have an aerosol drainage bag. Typically that aerosol drainage bag should be at the lowest point. There comes a little clip. You can hook that in, and ultimately, like I said, arrange that at the lowest place. That way the water that accumulates inside of the corrugated tube and gravity can do its thing and allow it to drain down to this bag. Now, knowing that it drains down to that bag, there is a little red cap there, so you're going to want to make sure that you cap that, or else the water that runs into that bag is going to run into the floor, and it's likely when you walk into the room, you're not going to see the clear water on the floor, and you may take a trip, and depending upon how bad it is, maybe a trip to the ED. Hopefully not, but maybe so. So on that note, we're going to talk about the difference between the fraction of inspired oxygen and the fraction of delivered oxygen. So your FiO2 versus your FiO2. Is there a difference? There absolutely is. So we estimate that with a nasal cannula, and you place a nasal cannula inside of the nose, around the ears, tug up under the chin, that a nasal cannula at roughly 2 liters per minute, assuming a normal tidal volume, respiratory rate, and so forth, inspiratory flow pattern, this and that, you're going to roughly have about 28% oxygen that's being breathed in. Like we said, the air that you and I breathe without any type of supplementation of oxygenation is 21%. So when you provide supplemental oxygen via nasal cannula, where that's 1 liter per minute, 2 liter per minute, 3 liter per minute, and so on up to, with a basic standard nasal cannula, you go up to 6 liters per minute of oxygen. Once you get up, it's kind of nice after you go up above that 2 liter mark to go ahead and begin to add some a bubble humidifier to that. I know you've covered that before, and the focus of what I want to go over today is the difference between FiO2, FiO2, and then get into how the air entrainment devices actually work. So with that being said, let's backtrack to the flow meters. So you all will be tasked with some different outlets or inlets in the, and I say inlet because vacuum is an inlet, because if you're utilizing vacuum, it's going to suck the air that in here through these pipes to provide suction, so that you can provide suction to the patient, whether or not you, or if you need to suction them or what have you. And then you've got a medical air outlet and a medical oxygen outlet. The medical air outlet, typically in the United States, should say medical air on it, but it should also be yellow in color. The medical oxygen outlet should say medical grade oxygen and be green in color here in the United States. Notice I'm holding these little barbed adapters, these little Christmas tree adapters. These may come in different colors as well, so you may see yellow ones. You could potentially see clear ones. The hospitals that I've worked at or working at have gone to clear ones. And the reason for that is because if these are green in color, they're barbed adapters, or they do kind of look like a little Christmas tree, so you may hear them referred to as a Christmas tree adapter as well, or a nipple adapter. These have standard fits, so these will attach to a airflow meter. These will attach to an oxygen flow meter. So I can place this under the airflow meter just as such, as well as I can place it under the oxygen flow meter just as such. In a hurry, if you are identifying green with oxygen, if I happen to place this here and you're in a life-threatening code blue type situation, at a glance you see the green Christmas tree adapter, nipple adapter, barbed adapter, however you want to call it, and you attach your tubing here for your oxygen delivery device. The highest amount of oxygen possible you can provide to that patient is 21%, because it's 21% that's going to come from the wall. Doesn't matter if you turn it 2 liter, 3 liter, 4 liter, what have you. It's all 21% that's coming from the airflow meter. You also, just a little trip down memory lane as we're getting into oxygen therapy, you'll remember about the different safety systems associated with oxygen delivery device. So you've got the diameter index safety system, which is on display here. So that means that an airflow meter is only going to attach to an air outlet. A vacuum regulator is only going to attach to a vacuum inlet. And an oxygen flow meter is only going to attach to an oxygen outlet because of the different diameters. With the cylinders, E-cylinders, and smaller, you know that you've learned about the pin index safety system. So you've got the pin positions 2 and 5 and 1 and 5 for oxygen and air that we can remember. Ultimately, what that means is that if you draw an imaginary line on that yoke or valve stem, the pins are going to be positioned so that the airflow meter would only go into an air cylinder, and the oxygen flow meter, those pins are positioned so that those would only going to fit into an oxygen cylinder as well. And our working pressure for respiratory therapy equipment is 50 psi. So, and these two flow meters are calibrated at 15 liters per minute. Can they deliver more flow than 15 liters per minute? Sure. Let me just listen. So turn that's 2 liters, and when you're setting your flow, make sure you're reading it at eye level and that ball is bisected by the number or the line going through the number. Don't look at it from an angle because you may set the wrong liter flow. So I'm going to go ahead and turn this up to 15. That's 15 liters per minute of flow. You can hear the intensity behind that. Can that flow meter put out more than 15 liters per minute of flow? It certainly can. We're just only calibrated to 15 liters per minute, so don't really know what is. So let me just listen to the change. So it does put out more than 15 liters per minute of flow. However, above 15, because it's only calibrated to 15, we don't really quite know. So backtracking to fraction of inspired oxygen, fraction of delivered oxygen, FiO2 versus FiO2. And the selection of a low flow device, high flow device. Low flow devices do not meet or exceed the patient's peak inspiratory flow demand. High flow devices will meet or exceed the patient's peak inspiratory flow demand. So what we've got to do is decide how much supplemental oxygen the patient might need. Because if a patient's wearing a nasal cannula at 1 liter per minute, you can estimate that it's 24%, your FiO2 is 24%. With that being said though, what is the FiO2 through that nasal cannula? So if I have a nasal cannula hooked up to an oxygen flow meter, it's hooked up and I adjust it to 2 liters per minute, or just stick with the example I was using, I'll go with 1 liter per minute. So I put this nasal cannula, I don't have one with me, but I place the nasal cannula on the patient. It's in their nose, in their nares, and they're breathing in through their nose. As they breathe in through their nose, they are going to breathe in that 1 liter per minute of supplemental oxygen that I have going in through the nasal cannula. But because their inspiratory flow is going to be greater than 1 liter per minute, they're also going to breathe in more of the 21% room air that's in this room, and that's going to dilute the amount of oxygen that's going in. So that's how we basically say that there is roughly 24% oxygen at 1 liter per minute, because the FDO2, the fraction of delivered oxygen through that nasal cannula, it's 100% oxygen coming out of the wall. So 100% oxygen at 1 liter per minute coming out of the flow meter through the nasal cannula to the patient is 100% oxygen of 1 liter. Now this patient breathes in, and they breathe in significantly more than 1 liter per minute. There's going to be 21% room air that mixes with that 100%, and it's going to knock the actual FiO2, the fraction of inspired oxygen, it's going to knock that down to roughly, we estimate, 24%. And you can add 4% to that for every liter above 1 liter that you, so 2 liters would be 28%, 3 liters would be 32%, et cetera, until you get to 6 liters. And then at that point, if you're having to go up higher than that, you're probably choosing some type of alternate means of supplemental oxygenation. So then, that being said, the FDO2 from the airflow meter is 0.21. The FDO2 from the oxygen flow meter is 1.0. It's 100%, 21%, 100%. The difference is, are we meeting or exceeding the patient's peak inspiratory flow demand, and are we utilizing a device that we can set a specific inspired amount of oxygen, and then we go from there. Let me check the time real quick, see how we're doing. All right, so I'm gonna pause here. We'll pick up the next video in just a second.